piperacillin combination is available. So let's come to the quinine, which is an old drug, which was the drug of choice for a long time for both the malaria. But now, because of the availability of better agent, less toxic agent, more efficacious agent, as well as uh, availability of wide range of drugs, the quinine is obsolete and not used. It is obtained from cinchona bark. You all know the plant root, and it is high efficacy erythrocytic zygonticide, which has no action on erythrocytic stage. So primaquine should be given, and it gametocidal against vivax and malaria, and it should be given along with primaquine for vivax malaria. So gametocidal में not only primaquine but quinine is also having gametocidal action. That's why quinine was the drug of choice earlier. The single drug is given to treat the malaria, whether it is vivax or falciparum, doesn't matter. So that's why it was very commonly, because it is very toxic. It is now not used. So resurgence is that most chloroquine and multi-drug resistant of falciparum still respond to it. This is what we call resurgence. So earlier there was a resistance to chloroquine quinine developed, but nowadays most of the, because we stopped using it, now the new plasmodium is not recognizing quinine. So again it is become sensitive to the quinine. Quinine, this is what we call resurgence. So, though effective in terminating an acute attack of falciparum malaria, it may not prevent recurrence, indicating incomplete clearance of the parasite. So, it may not prevent recurrence. This is one thing, one problem with quinine. So, doxy and clindamycin is mostly added to it for complete parasitic clearance. So, whatever regimen we will see later on, you will find these additional drugs. Whatever additional drug is we are adding is just for complete parasitic clearance. Mechanism of action of quinine is same as chloroquine, that as it is also a weak base which get concentrated into the acidic food vacuole of sensitive plasmodium and inhibit the polymerization of heme to hemozoin. And that free, because there is no polymerization of heme to hemozoin, the free heme which is toxic will lead to the damage to the parasite. The same mechanism of action is here as chloroquine. So after oral administration, quinine is rapidly absorbed, reaches peak plasma level in 1 to 3 hours, and is widely distributed in the body tissue. As I am telling you again, we no more use quinine for the treatment of malaria, but this is why we are reading and discussing that you should know the history of treatment of malaria in our, and very recently quinine is removed from the regimen, but still in some places we use quinine where there is chloroquine resistance and we do not left with any option, we use quinine. So the use of loading dose in severe malaria allows achievement of peak level within few hours. So we always give loading dose. You will see that we were giving chloroquine loading dose as well. That is 600 mg start dose, then followed by 600 mg after 6 to 8 hours and 300 mg daily. Similarly, in quinine also we give loading dose of 10 mg per kg. You will see that, and it is cardiodepressant, and hence it is useful as antiarrhythmic. So ADR is something which is very important to read as far as quinine is concerned. It is intensely bitter and irritant. So orally very difficult. Parenterally you can give. Orally it causes nausea, vomiting, epigastric discomfort. Severe nausea it can cause. Injection can also cause GI toxicity. It's not like only oral drugs of quinine is responsible for GI toxicity, but injections can also not only cause pain and local necrosis, but also lead to GI toxicity. And if you give by IV route, it can lead to thrombosis in the vein. High dose or rapid IV, just like chloroquine, can lead to hypotension, CV collapse, arrhythmia, hypoglycemia. So we avoid giving chloroquine by parenteral route. But earlier, quinine was the only hope, and for complicated malaria, we need to give it. So at that point of time, it is very important for us to take the ECG of the patient before starting quinine. If there is any abnormality in ECG, quinine is out of the question. And second thing is it should be given along with dextrose 5 because it causes hypoglycemia, and very slow IV infusion because rapid infusion lead to hypotension and arrhythmia. So these techniques were used to give quinine. If somebody asks you why ECG is required, why slow IV infusion of quinine is required, and why dextrose 5 is mixed with quinine infusion, so you have your answer now. It is also cause hemolysis like primaquine in G6PD deficiency patient, and it can lead to hypersensitivity reaction. There is one toxicity called synchronism, which is happens when the plasma concentration of quinine reaches to 30 to 60, very very high concentration. And what is the toxicity? What is the side effect for synchronism? This is very very important to remember. Synchronism is a phenomena which is happened by syncona derivatives. The toxicity of syncona derivatives like quinine. So nausea, vomiting, diarrhea, abdominal pain, headache, dizziness, flushing. These are the very common things, but visual disturbance are very, very dreadful, like blurring of vision, photophobia, diplopia, night blindness, altered color perceptions, reduced visual field, optic atrophy, and even blindness can happen with quinine. So you remember chloroquine causes bull's eye maculopathy, and quinine in very, very high dose or very, very high concentration in the plasma will lead to the blindness. Not only visual disturbance, auditory like tinnitus, deafness, and vertigo can also happen because of the involvement of ear nerve. So these all terms you should know. Synchronism, quinine lead to not only GIT or neuro but also visual and auditory toxicity. Tinnitus is the first symptom actually of synchronism. So with the involvement of ear nerve, so auditory and visual disturbance are possible due to direct neurotoxicity. Uses, as I told you, resistant malaria, falciparum malaria cases, you can use it because of the resurgence nowadays. So uncomplicated plasmodium, uh, uncomplicated cases of falciparum, we can give oral route, and in complicated cases of falciparum malaria, parenteral route can be given. And as I just as we just discussed that doxy and clindamycin should be added to the quinine for complete parasitic elimination from the blood and the body. So 600 mg 8 hourly quinine can be given either orally or by parenteral route, depending on the complicated or uncomplicated status of the falciparum malaria. And along with that, either doxy 100 mg daily or clinda 600 mg 12 hourly, that is twice a day, for 7 days should be given for complete treatment. So, what is the difference between complicated and severe malaria, including cerebral malaria? So, if there is uncomplicated, we are giving oral. The regimen is this: 600 mg, 8 hourly, along with either doxy or clinda for 7 days. But if it is complicated, we need to give parenterally. So, IV infusion is given where loading dose is 20 mg per kg, just to increase the concentration of quinine to kill the parasite effectively. We give loading dose. It should be diluted in 5% dextrose, as I told you, because it causes hypoglycemia, and it is very, very slowly infused over 4 hours. Why? Because if there is fast infusion, it will lead to hypotension, cardiac arrest, and arrhythmia. After 4 hours, the dose is reduced to half, that is 10 mg per kg, and given 8 hourly, and we give it orally as soon as the patient is able to take by oral route without any nausea and vomiting. The parenteral administration of the drug is shifted to the oral, and the dose remains same, that is 10 mg per kg every 8 hours, and complete the course of 7 days. But currently, artemisinin compounds are preferred and used by parenteral route. We will see those regimen as well. But the regimen of quinine, you should remember both oral regimen as well as the parenteral regimen. Now, we'll take a 5 minutes break, a fast break, and we will continue with our uh, rest of the topic after that 5 minutes break. So it is 12:07 in my clock. So we'll meet at 12:15. So take a 7-8 minutes break. Thank you. Am I audible? Am I audible? Thank you, Karthike. So let's continue. So this is pyrimethamine, and with this group of drug you already know. This belongs to sulfonamide group of drug, which inhibits the dihydrofolate reductase enzyme. So mechanism of action of pyrimethamine you already know. Okay. So it is a selective anti-malarial action. Its selective anti-malarial action depends on high affinity for plasmodial enzyme. So it is very selective. Those cells which are not infected by plasmodial will not be affected by pyrimethamine. So it is having very selective action. Of course, chloroquine, quinine, mefloquine, whatever the drugs we just saw, they are also have very selective action because they need something which parasite has. If a drug needs something to get activated, if parasite has, that means it is very selective. Any cell which is not infected by a parasite, or if the parasite is not there in that particular cell, the drug will not act. So this describes its selectivity towards plasmodium. What is the difference between trimethoprim and pyrimethamine? That it has very poor action on bacterial dihydrofolate reductase. So you can see here trimethoprim we used in uh, as antibacterial drug, right? Because it has very selective action on bacterial DHFR, but pyrimethamine has poor action. So pyrimethamine is having better action in protozoal, that is plasmodial DHFR. So we start using it here in treatment of malaria. So pyrimethamine is not a very highly efficacious and fast acting, but it is a slow acting erythrocytic cell and does not eliminate pre-erythrocytic phase. So it is neither good for clinical cure nor good for relapse. But yeah, it can be added to prevent resistance to many drugs, or it can be added to complete cure, complete elimination, parasitic elimination. So that's why it is important. So as clinical cure for Plasmodium falciparum, it is used in combination with sulfadoxine as sulfadoxine pyrimethamine uh, combination. So basically the dose is 1500 mg of sulfadoxine and 75 mg of pyrimethamine, but it is available as 525 combination. So 3 tablet single dose is given. Adverse effects are same, whichever whatever you read in sulfonamide group, the adverse effect are same. And because of the side effects, this single dose treatment of uncomplicated chloroquine resistant falciparum malaria came into the picture. This single dose 1575 mg of this combination sulfadoxine and pyrimethamine is being used because the reason is toxicity, sulfonamide toxicity. Because compliance is good due to single dose and very few side effects, it is recommended. And it is very commonly given as well. One combination is available, artesunate along with sulfadoxine pyrimethamine combination is available. And it is not only the combination available, but it is nowadays a first line drug for uncomplicated falciparum malaria. Don't get confused with complicated and uncomplicated. There is no much difference. Only thing is that when there is uncomplicated malaria, we try to give drug by oral administration, and when there is complicated malaria, we give it by parenteral administration. This is the only difference between complicated and uncomplicated. Otherwise, everything is same. We have obviously complicated are when there is severe symptoms, which cannot be which cannot be controlled by the oral administration of drug. In that case, we give parenteral. So nowadays, this combination of artesunate and sulfadoxine pyrimethamine is largely replaced chloroquine. So nowadays, we do not give any chloroquine tablet, considering the fact that the plasmodium is now resistant to the chloroquine. We do not have time to check whether the chloroquine sensitivity is there or not. So it's better to start artemisinin combination therapy, ECT, straightforward, with this drug of choice, artesunate plus sulfadoxine pyrimethamine. This is first line for whole India except the northeast region. We will see what is there for northeast zone. So this kind of kit is available. Artesunate, sulfadoxine, pyrimethamine. If you see the backside of this kit, you will find that there are three tablets of sulfadoxine pyrimethamine combination. So one tablet contains 500 mg and 25. So ultimately, the single dose this tablet contains 1500 mg of sulfadoxime and 75 pyrimethamine, and along with 6 artesunate tablets, 100 mg each. So this is given twice a day for 3 days, and this is given single dose on day one. So you can see here, day one, what you do: 3 tablets of A. So this all the 3 tablets, that is single dose sulfadoxine pyrimethamine, and 2 tablets of B, that is artesunate. So morning, evening, and then day two, 2 tablets of artesunate, and day three, 2 tablets of artesunate. So the regimen contains artesunate 100 mg BD for 3 days and sulfadoxine pyrimethamine 1500 plus 75 mg combination single dose on day one. Okay, this is all we are doing for the same reason, that prevention of development of resistance, decrease side effects, increase efficacy, and for complete eradication of parasite from the body. So, what is the role of clindamycin and doxycycline? They are also weak erythrocytic isotretinoin and can never be used alone to treat malaria, but yes, as an add-on treatment to other erythrocytic isotretinoin to uh, complete eradication of parasite from the body. All plasmodial species, they are effective: chloroquine, mefloquine, sulfa-pyridoxine resistant, P. falciparum. Uh, it can be used, never use alone, and it is used in combination with quinine. As I told you, quinine is not able to completely eradicate the parasite from the body, so it is used with quinine for that purpose. Now come to the artemisinin group, which are drug of choice nowadays. They are potent and rapid erythrocytic scissorticide. This is very, very important action. Quick parasitemia clearance. This is again a very, very welcome action of artemisinin. Within 48 hours, complete parasitic clearance can be seen. So it is obtained from plant Artemisia annua in Qinghao. So this is the plant source. No need to remember. It is active against Plasmodium falciparum, resistant to all other antimalarial. This is the big thing, that Plasmodium falciparum, which is resistant to all the available antimalarial agent, is still sensitive to the artemisinin, and hence nowadays we are using artemisinin, and not alone. It is in combination therapy, ACT, because we don't want it to get, the Plasmodium to become resistant to artemisinin. That's why we are not using it alone. So in erythrocytic cytokinin cycle of malaria parasite, artemisinin exert action on the ring form to early cyzones. So this ring form, early cyzone, hypnozoids, merozoids, these all terms you should read from your microbiology textbooks. No action on hypnozoids. So Vivex malaria, primaquine is to be added. So why we are adding primaquine? Because we want to prevent relapse, and any drug which is not active on hypnozoids or tissue cyzones should need an additional treatment of primaquine to prevent relapse in case of Vivex, and lethal to early stage of malarial gametes. So like quinine, artemisinin are also having gametocidal action, but still you can give chloroquine 45 mg single dose for that action. The mechanism of action of artemisinin group is that, so this hemes ferrous iron mediated cleavage of endoperoxide bridge leads to release a highly reactive free radical species which binds to the membrane protein and causes lipid peroxidation, damages endoplasmic reticulum, leads to lysis of the parasite. Okay, so this drug, artemisinin group of drug, what it causes, this the ferrous iron of heme mediate the cleavage of endoperoxide bridge, and because of the cleavage of endoperoxide bridge, it releases a very highly reactive free radical species with that destroy the multiple things in parasite like endoplasmic reticulum, lipid peroxidation, proteins. Now, a group of drug called halo and lumefantrine, where these are phenanthrene methanol group alcohols, basically. Chemically, they are alcohol, and they are potent blood isonticide against all the species of Plasmodium. But they do not have any gametocytosis action or any action on hypnozoites. Good thing about these drugs is the bioavailability enhanced with fatty food. So, with the dairy products, the availability or absorption of halofantrine, lumefantrine is good. So it is advised to be taken with milk. And the mechanism of action of these group is they inhibit the proton pump of plasmodium, and GI upset as other antimalarial drugs are causing it. They are also known to cause GI upset and QT prolongation. So if we come back to the artemisinin group, which are poorly soluble in water and oil, so there are many derivatives you will see in many regimens. We will see the regimen very soon now. So you will find many artemisinins like artemether, arteether, artesunate, arterolane. So some important points about these derivatives is that artemether can be given by oral route as well as intramuscular route, but not by IV route. Artesunate can be given by all the three route: oral, intramuscular, as well as IV. Then the active metabolite generated after the metabolism artesunate is also used. That is DHA. So DHA is dihydroartesunate, which is active metabolite of artesunate. It can be used. We'll see it also in the regimen. Then there is arteether, which is given by intramuscular route only, and it was produced in India. This is good thing that we produce one of the artemisinin, which can, but the limitation is it can be given by IM route only. Arterolane is totally synthetic. All these things, artemether, artesunate, dihydroartesunate, arteether, arterolane, these five are comes under the category of artemisinin. The duration of action of treatment with artemisinin is short. Recurrence rate is high when used alone in short course, so it is very important to give add-on combination therapy. So it is used only in combination. So what is the reason for ACT? That is artemisinin combination therapy. If somebody asks, you will say one thing is that to overcome the development of resistance, the most important thing. Second thing is to reduce the side effects. Third thing is to make the body completely free from the parasite, and that's why recurrence rate will be reduced. So here comes the artemisinin based combination therapy, that is ACT. Artemisinin based इसलिए बोल रहे हैं because every combination therapy is having one artemisinin. So this first one is artemether lumefantrine combination. So artemether lumefantrine both protect each other from plasmodial resistance. This is one thing. High clinical efficacy, active even in multi-drug resistant plasmodium falciparum areas. So wherever there is multi-drug resistant falciparum, still artemether lumefantrine is effective. Artemether is quickly reduces parasite biomass and resolves symptoms, while lumefantrine is added to prevent recurrence. So artemether is the artemisinin. The only disadvantage with artemether is that they are not able to, artemisinins are that they are not able to prevent recurrence. So we need to add something. So we added lumefantrine to prevent recurrence. And also they are having gametocidal action. Second regimen is artesunate sulfadoxine pyrimethamine combination, which I said is the first line drug for uncomplicated falciparum malaria in India. And I told you in Northeast region we use different regimen. That regimen is artemether lumefantrine. Then there is another regimen, artesunate and mefloquine, which we already discussed when we were discussing mefloquine. They are very highly effective and well tolerated in uncomplicated malaria. Then there is one combination is artesunate amodiaquine. This also we discussed when we were discussing amodiaquine. So in African countries, it is first line. India में first line क्या है? Artesunate plus SP, sulfadoxine, pyrimethamine. इंडिया में नॉर्थ ईस्ट में है आर्टिसोनेट ल्यूमेफेंट्रिन. अफ्रीका artesunate amodiaquine. Why it is different in different countries? Because of the resistance pattern in different area. Then there is dihydroartemisinin DHA piperacquine combination. This we discussed when we were discussing piperacquine. So 8:1 ratio mein we add piperacquine with DHA, and there is more than 98% response rate in uncomplicated malaria in India. So it is a good choice of drug in India also. So we made these combination in priority basis. Like first choice is artesunate SP combination. If there is any problem with that, we can go to another regimen. Like we can go to DHA piperacquine, or we can go to artesunate mefloquine, or we can go to artesunate atavaquone. Or the area where lumefantrine is sensitive, we can give lumefantrine combination. Then there is one regimen, arterolane piperacquine. So you need to remember these combinations. ACT is important to remember. Artemisinin based combination therapy. What are the various artemisinin and what are various combinations available? And which one is first line in India? Which one is first line Africa? Which one is first line in Northeast India? This you need to remember. I already told you. Now, arterolane acts rapidly at all stages of asexual schizogonia of malarial parasite, including multi-drug resistant Plasmodium falciparum, but has no effect on hepatic stages. For Vivex, this combination ACT plus primaquine is given. Why primaquine we are giving? Primaquine is given to prevent relapse at the dose of 15 mg per kg per day for 14 days. One more combination is available, artesunate pyronaridine, in the ratio 1:3, more than 95% cure rate, but it is not approved in India. If there is falciparum malaria during pregnancy, what should be the treatment? First thing is it is a very serious condition and prompt management is required. Quinine 300 mg plus clindamycin 300 mg twice a day for 7 days can be given in all trimester, but we choose it to given in first trimester only. Actually, we can give ACT. We want to give ACT, but in first trimester, it is not safe to give ACT, artemisinin based combination therapy. So in first trimester, we use quinine 300 plus clindamycin 300 mg combination. The problem with using quinine in first trimester is, just a minute. So the problem with using quinine in first trimester is that they itself cause nausea and vomiting. And in first trimester, there is a lot of morning sickness to the lady. So it is very, very difficult to tolerate quinine clindamycin combination. But we do not have any choice. So in first trimester, quinine clindamycin combination is given. And then in second and third trimester, 3 days ACT treatment is given. So all the regimens we discussed here, severe and complicated falciparum malaria. So when you say that a malaria is now complicated or severe, okay, we were discussing it since long, complicated, uncomplicated. But when you will say that when malaria plus one or more of the following, if malaria along with hyperparasitemia or hyperpyrexia, that is more than 102 temperature, if there is fluid and electrolyte balance, there is some sign of dehydration. If there are sign of acidosis, hypoglycemia, prostration, cardiovascular collapse, jaundice, severe anemia, spontaneous bleeding, pulmonary edema, hemoglobinuria, black water fever. So what is black fever and what is black water fever? Black fever means kala azar. That is different thing we will see in other protozoal infection. And black water fever is the name given to the cerebral malaria. That is complicated falciparum malaria. So renal failure and cerebral malaria, these are the condition where we called it complicated and we need to give parenteral drug administration. So parenteral drugs have to be used. As soon as the patient improved and able to take orally, we shift from parenteral to oral. Intramuscular artemisinins are preferred, or otherwise we can give intravenous artesunate. Mostly intramuscular injections are preferred. And quinine replaced used only when artemisinin cannot be used, like first trimester pregnancy. This is the guideline for treatment of complicated malaria. So here we are now ready with the dose regimen. We almost completed the pharmacology of all the available anti-malarial agents, and this dose regimen also we discussed. Now we will see this dose regimen with the correct strength of the drug as well as the duration and frequency of treatment. But before that, let's check the attentiveness of the attendees. So I am hereby launching a poll, and I am expecting you to answer it. So here is a poll in front of you now. So time is there. You can see the time. I am giving 2 minutes for you to attend the poll. And as I already said, in analytics software, we can see who, out of all the attendees, how many of you attempted the poll. Those who are attempting the poll will be considered as present in the class. Otherwise, rest all are considered absent this class. One more minute. Last 15 seconds. Five seconds. So this time 38% of you voted. But anyway, let's see. I'm closing the poll. 40% voting I got. So out of all of you, I can see here 229 attendees. Out of 229, 42% voted for this question will get the present, and rest all of you are absent. I'm sorry to say. You can continue hearing this lecture. You can continue. Maybe you are not there, but it's okay. So those 42% who voted will get the attendance for all the classes. Now don't raise your hand and don't say anything. Your chance is over now. So the Poll was parenteral route of drug administration is preferred in treatment of complicated malaria, which already discussed. Still 21% of you mark false, which is very, very disappointing. I can see, I can check who, because it is not only about attending the class, it is about listening as well. So first requirement to get attendance is to attend the class, not only by registering the link you think that you will get present mark. No. So whatever, whoever is voted for these polls will get the present, and all of rest of you will get the absent. In these also, whoever is marking the wrong, it means they are not listening. So this is again will considered as absent, but I will see what to do with those who are marking. A very, very simple statement is there, and many times I am saying, still if 21% of you are marking false, it means you are not listening. So with that, let's continue with our drug regimens. So here comes artesunate, artemether, arteether. Sorry. So you see here three artemisinin mesinins. Their regimen is given. When you give artesunate, artemether, arteether in complicated, where we are giving parenteral. So 2.4 mg per kg IV or IM of artesunate, because artesunate is the only artemisinin which can be given by IV route. Rest all are given by IM, and arteether can be given by only IM route. So artesunate is 2.4 mg per kg IV or IM, followed by 2.4 mg per kg after 12 to 24 hours, and then once daily for 7 days. So the dose is not changing; it is same 2.4 mg per kg. The only thing is, first we give 2.4 mg, and then we give it after 12 and 24 hours, and then after 24 hours after third dose every 24 hours for 7 days. And as soon as the patient recovered, as soon as patient able to take orally, we shift from parenteral to oral administration. Artemether dose is 3.2 mg per kg on first day. This is the loading dose, followed by half dose, that is 1.6 mg per kg for next 7 days. And artemether dose is 150 mg daily for 3 days. This is very, very simple. 3 days dose of 150 mg intramuscular injection daily. This is commonly used in our country. WHO says use it for 5 days, and it is for adults only, not for children, because of intramuscular injection related injury. So summary, if we summarize our anti-malarial therapy, you can see here, see, for uncomplicated malaria, for Vivax, Ovel and Malaria, if it is chloroquine sensitive, the available regimen is chloroquine plus primaquine. Why? Because primaquine is here used to prevent the relapse. So chloroquine, primaquine. Or if there is chloroquine resistance, quinine plus doxyclinda plus primaquine. And best is ACT plus primaquine. So primaquine is with all the regimen with chloroquine as well as quiniquine doxy combination as well as ACT, because primaquine here we are using for prevention of relapse, because we are talking about Vivax Ovel. And quinine is never given alone, it is also given along with either doxy or clinda. Now come falci. Chloroquine sensitive falciparum and drug of choice is chloroquine plus primaquine. Here you are giving chloroquine and primaquine. Here again primaquine is given, but not similar to earlier one. Okay, you can see here. Here you are giving chloroquine primaquine, but here primaquine is given by 15 mg per kg for 14 days to prevention of relapse. While there in falciparum, we are using again chloroquine and primaquine, but here primaquine is given a single dose 45 mg because there is no relapse in falciparum. Here we are giving primaquine for gambetocidal action, which will prevent the transmission of parasite from human to the mosquito and to the community later on. If there is resistance to chloroquine, the best group is artemisinin based combination therapy. There are multiple regimen. I told you the first line is artesunate SP in our country. It is artemether and lumefantrine in Northeast, and artesunate mefloquine in Africa. Atyrol and pepperquine can also be used. Quinine, doxyclinda can also be used because of resurgence nowadays. Quinine is used if there is resistance to artemisinin combination therapy. These are the dose regimens which I discussed. If there is chloroquine resistance, falciparum, malaria. See what are the different terminology we are using. First thing is complicated or uncomplicated. If it is uncomplicated, we are giving by oral administration. If it is complicated, we are given by parenteral administration. Again, whether it is Vibex or falciparum, then again, whether it is chloroquine sensitive or chloroquine resistant, this is the basis of choice of regimen. So if you talk about chloroquine resistant falciparum malaria uncomplicated as a parenteral administration will not give, we will give oral administration, and because it is chloroquine resistant, we will not give chloroquine. So the choice is artesunate 100 mg BD for 3 days plus mefloquine 750 mg on second day and 500 mg on third day. So one regimen is this. So 6 tablet of artesunate, that is 100 mg BD for 3 days. 2 tablets of mefloquine. One tablet is 750 mg. Other tablet is 500 mg. One tablet is given on day 2 and second tablet is given on day 3. So day 1 artesunate, day 2 artesunate plus mefloquine 750, and day 3 artesunate plus mefloquine 500. Or you can choose another regimen, that is artemether 80 mg and lumefantrine 480 mg twice a day for 3 days. This is another regimen, whatever you choose. Then comes third one, that is artesunate 100 mg BD for 3 days plus SP, that is sulfadoxine pyrimethamine single dose. This we already seen when we were discussing artesunate. That is day 1 you give artesunate 100 mg BD and one single 3 tablets or one single dose of 1500 mg 75 mg combination of sulfadoxine pyrimethamine. Then day 2 artesunate, day 3 artesunate. Another regimen is either you give arterolin 150 mg plus piperquine 750 mg once daily for 3 days. Okay. Another regimen is quinine 600 mg 8 hourly and for 7 days in combination with either doxy or clinda. If you are giving doxy 100 mg daily, if you are giving clinda 600 mg 12 hourly. This we already discussed. So this is all about the pharmacotherapy of malaria. In next class, that is on Tuesday, we'll get 3 hours and we will finish the whole antiviral and antiretroviral therapy. And after that, we will discuss antifungal agents. After that, two more class. One will be on antihelminthic drugs and one will be on antiamoebic is left as far as chemotherapy B is concerned. So, if you have any doubt, you can ask. I am waiting for some time. So the question is, why is primaquine not given for with ACT for gametocidal action? Shashwat, I told you ACT artemisinin group of drugs are having gametocidal property. Even quinine is also having gametocidal property. So it is not required, but still in some cases because they have weak gametocidal action, sometimes you will find primaquine 45 mg single dose. So it's okay, both the regimen. Although because ACT is also already having gametocidal property, it is not necessary to give clindamycin 45 mg single dose as gametocidal action. I hope I am clear, Sashwat. Okay, thank you. Any other question? If no more question, It's okay. You can leave the class. I am switching it off. See you on Tuesday. Good day. Bye bye. Okay, I can see one more question is that why can't we give primaquine orally? No, we can give primaquine orally. We give primaquine orally. I told you 15 mg per kg, 15 mg per kg. Sorry, not 15 mg per kg. 15 mg for 14 days. In case of prevention of relapse, Chitranjan, we gave it orally, and 45 mg straight single dose for gametocidal action we give orally. Yes, we give primaquine orally. Am I clear, Chitranjan? Okay, thank you. Any more question? I am waiting.